Welcome everybody to our TIF Talk Tuesday. Thank you for joining us. My name is Andrea Millers and I'm with Endogastric Solutions. Today, I'm excited to have a special guest, Dr. Kalpesh Patel. Thank you for being here today. Dr. Patel is the director of the Center for Advanced Endoscopy at the McNair Campus of the Baylor College of Medicine in Houston, Texas. His gastroenterology practice includes special interests in interventional endoscopy and medical education. Welcome, Dr. Patel.
Oh, thank you, and thanks for having me. Looking forward to a good talk.
Yeah, thank you. So for everybody that is watching, I do want to remind you this is live. So at any time, please feel free to ask us any questions or ask Dr. Patel any questions by typing the questions into the chat box. And we'll do our best to answer the questions throughout the event. So again, thank you for joining us. And we'll go ahead and get started, Dr. Patel. So we're talking about GERD today and the TIF procedure. So maybe you can give us a scientific explanation of what GERD is or what the symptoms of patients would feel if they have GERD.
Yeah, it's a great question. Sometimes we overlook the basics. So we talk about GERD. I like to just think about what the letters stand for. So GERD is G-E-R-D. The G stands for gastro, so that's your stomach. The E is your esophagus. That's what connects here from your mouth to your stomach. And the R is reflux, meaning movement of contents from the stomach into the esophagus. And the D is disease, which is a general term we use to indicate that it's something that's causing you a problem. So all of us have some reflux on a daily basis, whether it's acid or some of the other stomach contents will come up into our esophagus, particularly when we eat or after we eat. But most of us don't feel it. It's very brief, doesn't cause us any problems. GERD refers to the situation where you have prolonged reflux. You feel it, it causes you discomfort. And it lasts for a period of time or is reproducible. And that's where usually I'll get involved and talk to patients about making a diagnosis and beginning to talk about treatments for GERD. The other thing is, we obviously have a lot of different synonyms we use for it, and most of us are familiar with heartburn. Heartburn is a symptom. It's that burning pain you get right here, kind of in the lower middle of the chest. Mm-hmm. And it may be one of the many symptoms of GERD, the condition. For others, it may feel like pressure. Some folks experience cough, hoarseness of their voice. Others may actually experience chest pain. So the condition of GERD encompasses a pretty wide range of symptoms, but all of it really ties back to contents, whether it's acid or other stomach contents, coming up into the esophagus and causing discomfort. Right.
Thank you. So we have a little fact or fiction about GERD. There's a lot of things that people think GERD is, and then there's a lot of things that are not true, right? Mm-hmm. So let's talk about what's this? Reflux isn't just acid. Fact or fiction?
That's a great question. So it's not just acid. Really anything from your stomach can reflux up. Some of you may have learned that the hard way after a bad meal or so on. You've seen what can come up. So well, although typically we think about acid, which is what often causes that heartburn, we can also have what we call regurgitation of liquid. So your stomach also contains other juices like mucus or bile, or even what you just ate. All of these can regurgitate, meaning go from the stomach through the junction between the stomach and the esophagus and up into your esophagus, the back of your throat, and so on. So it is important to consider not just acid, but the other things that can reflux as well. And that also gives us some explanation to why certain patients won't have much relief with some of the traditional treatments, such as antacids.
Right. Okay. So let's talk a little bit about managing GERD. Are there different lifestyle modifications or activities to minimize the symptoms from GERD?
So first thing I like to do is really get a sense of the severity. We want the treatment to match the severity of the illness. So we don't want to underdo it or overdo it, but try to match it or personalize it to each patient. So we generally think of GERD as having mild and severe forms. Mild is usually limited to just the symptoms, whether it's heartburn, cough, etc. They tend to be infrequent, and they tend to be mild in nature. So someone like that, we would focus on touching on any reversible factors, whether it's diet related. There's certain things that can exacerbate reflux. And we'll get to this in a little bit, but the mechanism, maybe it's worth touching on that for a second.
Sure.
Our esophagus and our stomach meet together at a very critical point called the esophagogastric junction. And it's actually a fairly complex junction that's composed of different muscles. Some of you are familiar with the sphincter that lives down there. And that sphincter opens and closes as we eat and in between. And one of the mechanisms of reflux is the failure of that sphincter to close completely after eating. That may be most pronounced after you've eaten. Pressure is built up in the stomach and you push up on that. Or in some cases where it never really closes at any time, you may have continuous reflux. And some of those folks may really have severe symptoms, particularly when they're laying down at night and so on. So in terms of treatment, I really start by figuring out the severity of it. How often are you having symptoms? Are they only when you eat or at random times? Do they wake you up at sleep and so on? Yeah. Once we have that, we try to tailor the treatment. So again, for milder cases, we'll talk about avoiding, very large meals, certain types of foods. Unfortunately, there are some of the good ones. Alcohol, chocolates, mint. These are all known to relax the sphincter muscle. Some things we can do that are simple, sort of at night, raising the head of the bed with a couple pillows if you have problems, particularly at night. And then the one thing we really have learned plays a big role is your weight. Many folks will even notice on their own observations, if after a holiday season they've put on some weight, they'll notice increased reflux. So oftentimes I'll focus on, what are some simple things we can do to maybe lose a small amount of weight to see if that alone takes care of it.
Okay.
In more severe cases where the symptoms are more frequent, last longer, and perhaps the patient's already tried some over-the-counter medicines without relief, usually there we'll begin to think about either medications and or additional testing to better characterize what may be the underlying cause of their symptoms.
Right. Perfect. Thank you. So we do have a couple of questions that have come up, so I'm just going to ask a couple. One is from Nicole. She's saying, is GERD life-threatening?
That's a great question, Nicole. And so GERD itself, typically for most people, will be more of a nuisance or a bothersome than anything else. However, it is important to note that in a small percentage of people, it can predispose to some pretty serious complications. And one of the things that can happen, particularly if you had acid reflux for a long period of time, usually we're talking about years, and that may be with you knowing it or not knowing it. That can cause damage to the lining of the esophagus. It starts off as ulcers or esophagitis, and with time, that can progress to a condition called Barrett's esophagus. Really, that's your body's attempt to kind of protect itself. The lining of the esophagus develops this change, which, although may be protective against acid, anytime your body starts changing like that, there's a risk that it can keep changing in an uncontrolled way. And what we've learned is Barrett's esophagus in some folks can actually be precancerous. And in a very small percentage, they do have a risk of developing esophageal cancer. So certainly that's not true for most people. However, there are a subset of folks who've had uncontrolled GERD can develop into a fairly serious condition.
Yeah, thank you. We get lots of questions about Barrett's and how that affects how GERD affects that, as well as esophageal cancer. So I'm glad you touched on that. Let's talk a little bit about treatment options for GERD. What are the different treatment options?
Sure. So again, once we've gone through some of the lifestyle things, maybe some weight loss, a little bit of diet adjustment if there's a excess use of certain things, then usually we're looking at medications. And these are cases that may be situational, is the way I think of them.
Sure.
You're going on a big trip. You're going to be maybe eating out more than usual. And there, it's not unreasonable to use medications. Here, we're talking about antacids. And I like to take a step-up approach. We'll begin with simple things, whether it's over-the-counter antacids, or if needed, I will prescribe a prescription antacid, such as an H2 blocker, or in more persistent cases, we will use PPIs. Now, when I prescribe those, we tend to have limits on using them. We'll use them for maybe 2 to 4 weeks, and then we'll reassess. Maybe that's enough time to have made some changes in lifestyle. Maybe the acute event is past, and then we should make an attempt to decrease them. What we don't want is to just sort of make a single diagnosis and a single treatment and then leave that unevaluated for a period of time.
Right.
If after a few weeks we find that the antacids are helpful, but an attempt to discontinue them leads to recurrent symptoms, well, that's very important to know, because that gives us a clue that there may be a need for a more long-term solution. Whether that's focused on that junction that we talked about. And there is when we would begin to look into testing to see just how severe the situation is with the sphincter. Is there what's called a hiatal hernia, which is where that junction has shifted, allowing acid or other contents to come up. Based on that testing, we can then talk about some of the other non-medication options for treatment.
Okay, fantastic. So actually, I noticed there was an article that just released today on Times,
Yes.
on the Times. I think the topic is popular heartburn drugs linked to heightened COVID-19 risks. So it's kind of the elephant in the room in times that we're in right now. Do you want to talk about that a little bit?
Sure. Yeah, I'd be happy to. Yes, this was a study that was sort of in early press released today. And as you can imagine, everyone is very interested in learning anything and everything we can about COVID right now, looking for any possibilities of mitigating its effects. And that's done in medicine is sort of casting a wide net. And in this case, researchers performed a survey, internet-based survey, looking at folks, a wide variety of residents in the United States, and really just cast a net to see how many folks had COVID and asked them a series of questions about their general health. And one of the questions they asked was, have you been on a PPI, a proton pump inhibitor antacid medicine, in the months leading up to their diagnosis of COVID? And what they learned was in folks who were taking a single dose, there was about a 1.5 to 2 times increased incidence of having COVID. And those who were taking a double dose of PPIs had up to almost a 3 times incidence of COVID. Now, this is very kind of exploratory research. It doesn't tell us a cause or effect. But it does raise our eyebrows a bit to look a little bit deeper into this, and a lot more study will be required to see what the link is.
Sure.
My takeaway from it is, if you're on a PPI, this is just a good time to evaluate with your doctor. Hey, do I still need to be on it? Is it giving me any benefit? Have I tried to stop it and to see what the results are? Because that could really guide the next step.
Yeah.
As we've discussed, the problem or the fundamental problem in reflux is not that you're making too much acid or that you're making too many things in your stomach. It's that they're escaping the stomach into the esophagus more frequently due to failure of that sphincter at the end. So any medication that reduces acid, all it's doing is really taking away the acid, but it's not actually repairing the problem. With today's news, of course, I look forward to more research into it, but I would use that as an opportunity to just assess if you're on a PPI, to look into assessing your need and response to it.
Sure. That's a great recommendation. Now, can we talk a little bit, or can you explain a little bit about the different diagnostic tests or kind of the workup for understanding whether or not a patient would be a candidate for a surgery or whatnot?
That's very, very important step. As I mentioned in the beginning when we were talking about the definition of GERD, part of the definition includes the patient's sensation or their discomfort. And of course, it's very hard to put a number on that. And so we have developed testing to better quantify the severity or the nature of each individual patient's situation. So one of the more common things that we'll do is endoscopy. Endoscopy, of course, is a camera that's placed through the mouth into the esophagus and stomach under some sedation. And that allows us to get a direct visualization of the esophagus and the stomach and that critical junction between the two. And some things that we're looking for when we do that is there a hernia, meaning has the stomach or is that junction shifted in your body that's preventing it from closing very tightly? Has the acid caused damage to the esophagus, like we discussed earlier with esophagitis or even Barrett's esophagus? And it also allows us to check the status of the stomach. Are there any ulcers or concomitant bacterial infections that may also predispose to reflux? So that's a very common first step. Oftentimes I'm seeing patients who've already had that part done and are still struggling with sort of what's the next step in my reflux. And there we often will consider what's called pH or acid testing procedures. And this is very, very cool, if you ask me. It's a way for us to actually record the frequency and severity of your reflux using an instrument, a probe. There's a variety of kinds. Some are placed internally, some are attached to a very thin nasal catheter, and they actually kind of sit in the middle of the esophagus, very, very small. And they record the level of acid and other reflux items into the esophagus anywhere from 24 to 48 hour period of time. And during that time, you're actually encouraged, you're able to eat and drink your regular way in order for us to see what really is going on. And because what we want to do is, we certainly have a lot of respect for what a patient is feeling. We want to make sure that matches up with what's happening from a physiologic standpoint so we can choose the treatment accordingly.
Perfect. Thank you.
Mm-hmm.
So we've got more questions. I'm going to go ahead and ask questions. Tara's stating, my husband has been diagnosed with GERD. My question is, what complications could occur if he does not take his prescribed PPI or change his diet?
Yeah, that's a probably the most immediate complication is he'll be cranky with you after every meal you eat.
We don't want that.
Yeah, but it's an important question. In long term, there are some pretty serious consequences. So, beyond the symptoms and the discomfort and really the impact on quality of life, I don't know if it affects him, but a lot of my patients, have trouble sleeping. They're woken up by these symptoms. And we all know, not just we joke a little bit about the crankiness, but poor sleep has serious health effects. The acid itself can contribute to damage to the lining of the esophagus called esophagitis. In some cases, that could lead to scarring of the lower part of the esophagus, and he actually can develop difficulty swallowing his food, and even have an episode where food can get stuck, if not, in severe cases. Although it's rare, and I don't want to alarm anyone, but if we do take it seriously, it can lead to the development of a precancerous condition as well. So I do encourage him to take his medications, one, to get some relief, and also to give his doctor some idea of if he needs to be evaluated for a longer term solution as well.
Perfect, thank you. We have another question from Rajesh. Dr. Patel, I have had GERD for the last 20 years that had to be treated with dilation once every 6 months to a year. I was put on omeprazole 20 milligrams and now shifted to
Reprazole, yeah.
Sodium powder 20 milligrams, which has resulted in regurgitation. What line of medication do I need to follow?
Well, that's a great question. It sounds like you've been really working on it for quite some time, and
right.
That's not uncommon. A lot of patients will deal with this for many, many years, and I think as just as a whole group, we often have kind of brushed aside heartburn a little bit, and I'm glad we're taking opportunities like this to talk about it more. So first off, if you've required dilations, that may imply that you had reflux to the point where it caused that narrowing, and so that's a I would consider that severe. And there, we really need to look at that junction between the esophagus and the stomach and see, is it really not functioning, and is that what's kind of creating this cycle? And like I mentioned earlier, that's a mechanical problem. And it's unlikely that a medication or a pharmacologic treatment will fix a mechanical problem. So it may have gotten a little complex after the dilations, and then if they're, once they're wide open, that lets the reflux back in, and it becomes this vicious cycle. If I were to see you, or I would encourage you to talk to your doctor about, hey, let's look away from medications for a bit. And are there some options to actually repair the underlying problem? How do I restore, the sphincter and the normal function of that area so I don't have to go?
Yeah, that's a perfect segue for our next topic. And I know you have a video you're going to show as well, but can you talk a little bit more about what the TIF procedure is and how does it work? And then you can show your video too, and I'm sure people would love to see that so they can see. Yeah.
Happy to. So once we've gone through the lifestyle changes, or we tried some medications, and we get to a point where someone's sort of feels like they're dependent on medications to keep this under control, or they've developed some of the other more advanced consequences, we really get serious about fixing the problem long term. And like I've emphasized, the issue really is at the lower end of the esophagus where it meets the junction, and how do we restore the normal function where that stays tight, opens when you're eating, and then closes back up again. And so there's a variety of ways to do this. Some of these are done by a surgeon through types of surgery. And one procedure that's available that can be done through the mouth through a camera. And that's a procedure I'd like to talk a little bit more about, and one that I've added to my practice, which is the TIF procedure. And I'm going to show a video here and to kind of demonstrate better than I can probably describe how this procedure works.
Perfect. That sounds great. And just so you know, Rajesh said, thank you, Dr. Patel, for answering this question.
Very good.
Okay.
Okay. Can you see the video there?
I can, thank you.
Okay, so here we can see the camera going through the mouth down into the stomach. And I'm going to pause there for a second. This is the device right here, and this is the standard camera. And so the camera is really showing me the view of how I'm managing the device. And here, I know I've been using my fingers to demonstrate, but here's a clear picture of the area that we're talking about. So here's the esophagus, here's the stomach, and here's this natural kind of tight area. This is where your sphincter is. And normally, we like for it to have almost like an hourglass or funnel shape, where it should kind of narrow or get tight and then open up into the stomach. But in folks who have GERD, what happens is you lose that narrowing here. Mm. So what we're going to do with the procedure is we're going to recreate the sort of hourglass or funnel shape by using this device to pull the esophagus tissue, the normal tissue, back down and to create a little funnel. So I'll show you how that looks here. The device is just going to gently advance up to the esophagus, and using a little grasper, we're going to take your normal anatomy and bring it down. And you can see the critical step there. Up here, we're narrowing the junction between the two. We're allowing this, which is your diaphragm, to actually do its job by pinching this junction as well. And in order to keep this in place, you're going to see a couple of fasteners get fired. And those are going to encourage or allow the body to heal in this position. Now, this is done in kind of a 270-degree fashion around the junction. There go the fasteners there. They look like little price tags, actually. And here's a nice view of what it looks like once we've gone around the area and pulled it down and created this really nice, tight, almost looks like a valve down here, okay? So now if you think about it from the perspective of acid coming from the stomach, it doesn't have a wide opening to enter anymore. It's going to more bounce around this valve, and very little will escape back up into the stomach, into the esophagus. The nice part about this procedure is, since it's done over that device, it can't get too tight. So that really protects us against some of the common side effects of traditional surgery, like the inability to belch or a feeling of bloating or fullness. I don't see that as often because we're using that device to create this valve over it.
Right.
Wonderful. I'm going to exit out of the video here if we've all gotten a good look at that.
Yeah, thank you.
All right. So, so that's again a good candidate for the TIF procedure. Again, someone who's maybe had a good response to medications, but finds themselves dependent on it or trying to get off of it without success. At that point, I'll perform an endoscopy and do the acid testing. We're looking for folks who haven't quite developed a very large hernia yet. Some folks, you'll be surprised, their stomach has shifted almost entirely into their chest. That, unfortunately, won't be a good candidate for this. But a lot of folks have a very small shift, one that can be pulled down very nicely. And then if the acid testing confirms it's acid, then I'll usually or often discuss the procedure as the next step.
Perfect, thank you. That was a great demonstration and explanation of the TIF. It's nice to see the visual as well, right? We do have another question. Rajesh again is asking, what would the cost of the procedure be?
It's a good question. One of the reasons we're even talking about the procedure is that although it may be new to those on the call, it's actually been around for quite some time. The procedure was developed over 10 years ago, actually, and it's undergone several refinements to really make it as effective as it is today. And because it's been around for some time, we've been been able to study the results. Unlike cases where there's not enough time to study it, we now have up to data on folks who've had this done, and we see what they're doing at 5 years, 6 years, 7 years. And actually, the positive results of these studies, actually was a turning point about 2 or 3 years ago, where that led insurance companies to begin to approve and pay for the procedure. And that was a real turning point for us, because it really allowed us to bring this to a wider group. So assuming you've undergone the appropriate testing beforehand to confirm that really is reflux, you meet the criteria, of course, the procedure would be submitted for insurance authorization. We do provide the necessary documentation to do that. Of course, each plan varies person to person, so I don't have a set amount I can quote for everyone, but I am happy to say that many insurance companies, Medicare for sure, are beginning to cover this within your plan.
Perfect, thank you. So let's talk a little bit about recovery from the TIF procedure. Can you explain maybe a little bit what someone would expect as far as hospital stay? What do they have to do post-op? Are there certain dietary restrictions after the TIF procedure? So on and so forth.
Very important points. And I've met a lot of patients who've told me that they, they never had surgery because they were more worried about the recovery than they were the actual surgery. So I think it is a good point to talk about. The procedure itself, it begins as an outpatient procedure. You arrive to the outpatient center. We typically advise everyone to prepare to spend 1 night in the hospital. It doesn't take more than that. And that's really more for comfort. The first, obviously the first few hours, but certainly the first couple of weeks are the crucial time. That's where the tissue inside that I showed you on the video, that's when it's sort of fusing and kind of settling into place. And it's that first 2 weeks that we really want to avoid any extra pressure or irritation to that area. And so there's 2 critical considerations. One is the diet, and it is going to consist of a full liquid diet during those first 2 weeks. And the second is we want to avoid increasing pressure inside our abdomen. And so there is a restriction on lifting weights. Especially during those first 2 weeks, nothing over 5 pounds or so. If those first 2 weeks go by and things are going well, the diet then gradually increases, and the restrictions we negotiate depending on what's important to your particular work or lifestyle to gradually reintroduce those. The nice thing about it is, unlike some of the other traditional procedures, we don't experience difficulty swallowing after the procedure. And so most folks are able to tolerate the liquids and so on really the same night and able to enjoy those during the recovery. So to summarize, about a night in the hospital, a couple weeks on liquids and no heavy lifting, and then gradually kind of returning back to normal after that.
Fantastic, wonderful. So a couple more questions. Carlos asked a question. I'm 27 years old. My symptoms are predominantly at night, as you had mentioned. I wake up 2 to 3 times per night. I'm taking omeprazole 40 milligrams daily for 14 weeks now. The head of my bed is raised, but I still wake up with a sore throat. This has been happening for like 2 months now, despite diet and medication. Could this be a sign I might need surgery? I was told I had a hiatal hernia 4 years ago, but it wasn't that bad.
Well, thanks for chiming in, Carlos. A lot of important points to discuss there. And the first is I want to note, I think you said Carlos is 27. Yeah. And, we've had a couple of questions about this, but Carlos, if he were to continue to have untreated or maybe incompletely treated reflux for many years ahead of him, I would worry about some of the long-term effects of reflux for him. So I'm really glad, Carlos, you're thinking about this now and not 20 or 30 years from now, where we may not have been able to avoid some of the more serious complications. Certainly, you've done all the stuff we've already discussed, and it sounds like you've required the medication for a long time. So absolutely, I agree. This would be a good opportunity to look into options for really fixing the problem, which in your case, you mentioned a hiatal hernia. That's again going to impair the ability of the sphincter to open and close properly. And so absolutely, if I were seeing you, we would talk about next steps being an endoscopy if you've not had that done, along with the acid testing to better characterize your reflux, and then talk about whether it's surgery, endoscopic like the TIF procedure, or one of the other options out there. I do think that would be definitely something worth looking into for you.
Fantastic, thank you. Another question from Mary. She's interested in knowing with antidepressants.
Yeah, great question. So thanks for bringing that up. And it's possible that along the way, if you've been treated or seen for reflux, and the typical antacids, PPIs, didn't work, you may have been surprised to have your doctor prescribe an antidepressant. Now, all that reflux may make you depressed, but that's not perhaps what we're going for there. What we've learned by carefully examining patients' symptoms, particularly heartburn, when we find that we aren't measuring acid reflux, they don't have a hernia, but they persistently have that symptom, we have a different classification for that. In that, there's a few different terms. One is functional heartburn, another is esophageal sensitivity, and those are very real conditions. And what it's not that they're having abnormal amounts of reflux or frequency, but what would be a normal sort of unnoticed reflux in me and you is a heightened sensation for those patients or someone like Mary. And so the approach there isn't necessarily to reduce the reflux, but it's to reduce the signal back up to the brain that's telling you that's uncomfortable. And so there, the antidepressants are used more for their effect on modulating or regulating that signal that something is wrong.
Wow, that's interesting. So let's talk a little bit. How long have you been doing the TIF procedure now, Dr. Patel?
Yeah, so I've been performing it, let's see, about 2.5 years now. Okay. Certainly I've learned a lot, really by talking to patients who come to see me for evaluation. I'll be honest, I don't, we end up choosing something else many of the times based on what's right for that particular patient. But as we've raised awareness of the options, we've been able to find more folks who are eligible and who are fantastic candidates for TIF, as we see more and more of these patients.
Fantastic. That just gets to kind of living GERD-free and after TIF procedure, after patients have the TIF procedure. Do you have any particular stories of any patients that have been very successful after the TIF procedure that you'd like to share with us?
Yeah, thanks for asking. There's a patient of mine that always comes to mind. She's a singer, and not like me in the shower, but a professional singer. She's actually enrolled in performing arts school. Oh, wow. And really came to see me at a critical point in her career. She was deciding whether she wanted to pursue singing as a career, and enrolling in a performing arts school, and really becoming prepared for that. And she realized that her reflux was going to be a big part of this. And she really, very thought hard about, what to do. And she was a little bit frustrated because she thought her reflux was going to really impact her ability to choose her career. So after seeing a few folks, she made it to me to discuss options. And, she was a little bit scared about the options before really knowing what they meant. She thought that, there was a chance of permanent damage to her vocal cords, not just from reflux, but from the procedure itself, based on sort of some, stories she had heard. She was worried about how much time she would have to take off from singing during the recovery phase. And she didn't want to risk, missing out on our important audition and so on. So much like this, we were able to have a nice, long, detailed talk about the pros and cons of all the approaches. We were able to map out, based on her schedule, the timing of things. And we selected for her to undergo a TIF procedure. We had to kind of time the recovery and everything around her schedule. And it really was a nice message to get that she was able to do her audition successfully. Nice. She chose to pursue singing. She's enrolled in school now. And she's really had a good outcome. So that's a good story. And, one of the more memorable ones for me.
That's great. So when she becomes famous, you can say that you had something to do with it.
Yeah, I'm expecting backstage passes for sure.
There you go. That's wonderful. Well, Dr. Patel, I can't thank you enough for joining us tonight, and for everybody who jumped on and asked questions. Thank you. This is, like, as you had mentioned, a unique time for us to be able to educate patients and really let them know that, they don't have to keep suffering from GERD. There's options and there's choices and there's physicians that are out there that can help them. So we really appreciate you joining us and answering all of these questions. So thank you. Any last comments or anything you'd like to leave us with?
Well, thank you for having me. And, we're doing this over video, virtual, and it brings up a good point. Although a lot of healthcare has been paused on and off as we deal with the pandemic, we don't want to forget about our regular health. And one of the things, one of the silver linings is we have begun to rely on telemedicine, video medicine, and so on to begin some of the evaluations and so on. And GERD and reflux is a perfect example of something that doesn't need to be delayed during this time. An initial discussion, just like this one, is more than adequate to begin to develop a plan for testing, a plan for initial treatment, and so on, so that when the opportunity is available for us to resume procedures, resume testing, we're ready to go with your plan. So thanks for setting this up, and I look forward to talking again.
Yeah, that's perfect. I'm glad you brought that up because, as you had mentioned, there's a lot of fear of going in. You don't have to wait, as you had mentioned, and the hospitals and physicians are taking all the precautions to make sure that patients are safe coming in. And then also telemedicine's been, we're very fortunate to have that. Right. So again, thank you everybody for joining us today. If you're in the Houston area, you can look up Dr. Kal Patel. And if you're not, please feel free to go on our website, gerdhelp.com. There's a lot of information similar to what Dr. Patel was talking about on GERD specifically, and also the TIF procedure. In addition to that, if you're looking for a physician in your area, you can go onto the physician finder on gerdhelp.com and put in your zip code or state and find physicians in your area. We also have a YouTube channel that you can view not only this TIF Talk that we are doing tonight, but all of the TIF Talks that we've had. And again, we do TIF Talks every Tuesday, so please feel free to join us every Tuesday. Times vary, sometimes 5 o'clock, anytime from there to 6 or 7 o'clock. So I hope to catch you next time. Dr. Patel, thank you again for joining us. And everyone, stay safe and have a good night. Thank you very much.